It was very interesting. And I leave the floor to Lina to introduce Professor Haddiya for the second part of our webinar. So thank you once again, Ustad.
Thank you very much. Thank you very much.
Thank you, Ustad, for your crystal clear and informative presentation. Once again, regarding diabetes during this holy month. And just to do the transition regarding Professor Haddiya Intissar's presentation, which will be regarding hypertension and CKD in, of course, this holy month context. Thank you.
Thank you. Thank you, Lina. Hi, everyone. So I'll try to share my slides first and then start the presentation. Okay, yes. Yes, here it is. Do you see my screen?
Yes, we can see your screen and can hear you well.
Good. So, good. So thank you. I'm really honored and delighted to be part of this very nice scientific meeting. And let me first express my heartfelt thanks to Servier Laboratories for the invitation and for organizing this webinar on this topic that is really of utmost importance for our patients in these days preceding the holy month of Ramadan. I really enjoyed listening to Professor Hassanin in his very detailed and documented and updated presentation. And I'll be, for my part, covering the hypertension and CKD conditions in Ramadan, because the hypertension and chronic kidney disease do also raise a lot of questions in our practice regarding whether the patient can fast or not. So, as we all know, currently there are more than 2 billion Muslims worldwide. Most of them are in Northern, Central Africa, South Asia, and the Middle East. And about 1.9 billion of adult Muslims do fast Ramadan because, as it's been said, it's a highly valued act. So even the sick, exempted, risk their life for this to accomplish this highly valued deed. And the uniqueness of Ramadan, just like the other months that belong to the lunar Islamic calendar, is that they start 11 days earlier every year, making it fall either in cold or hot season. So fasting hours do vary between the regions depending on the time of sunrise and sunset, making the fasting last 12 to 14 hours, but it can also last up to 18 or 22 hours at high latitudes, for example, in northern countries. With this long time fasting come lifestyle changes, sleep pattern disturbances, activity and meal intake time changes too, and they lead subsequently to endocrine process disturbances and dehydration risk. This was really well presented in this very recent and very nice paper about metabolomics of Ramadan fasting and associated risk of chronic diseases. In fact, in this paper, it's the London Ramadan study that was presented. It's an observational study that sought to assess the fasting effects on metabolites, including 72 participants, in which 2 blood samples were retrieved few days before and after Ramadan. The mean age of the participants was 45 years. And the findings was really interesting because it showed that Ramadan fasting is associated with many changes. Most of these changes they concern 14 metabolites, inflammation markers, amino acids, glycolysis-related metabolites, ketone bodies, triglycerides, lipoprotein subclasses, and all of these metabolites are independent of the changes in body composition. And the study did conclude to the presence of short-term favorable changes in the metabolic profile of risk of some chronic diseases such as hypertension, kidney disease, and several cancers too. But as it had been said, fasting might be harmful in frail people, those with acute and chronic conditions, or regular medication use. And these patients are generally advised to abstain from Ramadan fasting. But as you know, some of them still insist on fasting, and this is very challenging for us physicians because they're usually multimorbid and require multidisciplinary care. So let's delve into the situation of hypertension and Ramadan fasting based on the recent evidence. As you know, hypertension is the most prevalent cardiovascular disorder worldwide, with 1.28 billion adults affected, mostly in low and middle-income countries. And hypertensive heart disease is the leading risk for early mortality and disability across the world. So the link between hypertension and fasting, or the impact of fasting on hypertension, was well assessed in animal studies, just like the one that I'm presenting here. It's a very well conducted study that has evaluated the effects of alternating feeding and fasting cycles in mice and in Drosophila. So it has shown pleiotropic benefits involving multiple organ systems, such as the blood cholesterol, the fasting blood sugar, the body weight, the body fat, the inflammation system, mineral bone disease, and so on. So in animal studies, the fasting was really beneficial on so multiple systems. But what about fasting in humans and the link between hypertension and fasting in the human? Well, it's a unique model that is somehow different from the experimental fasting because in humans, there are other factors that do interfere. There are changes in medication timing, in activity, in the sleep pattern, and also in the food intake and possibly the salt intake. Besides, the effect of fasting on blood pressure in hypertensive patients was, or rather had been rarely well addressed and precise, as we see here in this systematic review in which the initial search strategy gathered 2,000 papers to end up at last with 5 relevant papers. So in these papers, we saw that in half of them, the authors found a significant reduction in blood pressure, systolic and diastolic blood pressure during Ramadan, while in the other half, there was no significant difference in blood pressure between the periods before and after Ramadan. In this most recent study, it's a Tunisian one, it had enrolled 60 patients. And what is interesting here is that a third of these patients were diabetics and 15% had coronaropathy. 37% of them were on dual therapy and 18% on a triple antihypertensive therapy. So here the results were also interesting because in this group of patients, there was no significant difference of the values of blood pressure between the period before Ramadan and after Ramadan, concluding to the fact that treated hypertensive patients may be assured that with the continuation of previous medication, fasting can be safe. But this is quite different from the other trials, such as one. This is an Indian trial that has shown, on the contrary of the previous one, it had shown a very significant, a highly significant difference between the values of blood pressure before and after Ramadan. In fact, hypertensive patients with the continuation of their antihypertensive medicines did witness a decrease in blood pressure and body weight at the end of the Ramadan fasting, while no change in serum cholesterol levels were observed. This Iraqi study did find the same thing regarding the blood pressure decrease that was equally highly significant, but it was not the only change or difference that was mentioned. There was also, it did also conclude to the fact that Ramadan fasting could contribute to the improvement of triglyceride levels, body weight, body mass index, and waist circumference of adult hypertensive patients. So with this being said, there are also other factors that should be taken into consideration when we speak about the variation of blood pressure, as it's shown in this old study published in 1998. It is the, as we said at the beginning, the variations of the sleep activity and eating patterns. That's what we're going to see in the few coming slides. So here, this is a very interesting study that's going to assess the effects of meal intake on blood pressure outside of Ramadan. In fact, the question here is whether the meal intake is going to lead to hypertension in patients or not. So in this study, they did include 9 healthy, normotensive, non-smoking male volunteers with a mean age of 20 years. And each of the volunteers had to accomplish 3 steps of the trial. The first step was cycling for 60 minutes. This was exercise. The second step was to ingest a quantity of fluid carbohydrates. And the third step was to do both, to cycle and to take the meal. The idea was to see the response, the blood pressure response after the exercise and the meal intake. So what we found here, as you see in the diagram, the blood pressure response was similar for post-exercise and post-meal, which means that healthy young subjects don't present hypertension after meal intake. This is explained by the fact that they have the ability to suppress hypertension by vasoconstriction. So meal intake does not induce hypertension when the patient is healthy and young. But there are other conditions in which we can witness postprandial hypertension. It's the case of patients who do have neurogenic orthostatic hypertension, as you see here in the diagram. These patients do present a significant drop in blood pressure after each meal. You see here the breakfast, the lunch, and the dinner. There is a drop, an abrupt drop in blood pressure after each meal, which is typical in neurogenic orthostatic hypertension and consistent with postprandial hypertension. On the other hand, during the night, we witness a nocturnal supine hypertension, and in the next morning, the orthostatic hypertension is even worse. Another condition in which we should beware of hypertension after meal intake is in healthy older subjects. And this is, or it can be explained by the slowing of the gastric emptying. It's well illustrated in this study that had included 30 participants with a mean age of 77 years. So these patients or these participants were followed up for almost 6 years, where the follow-up was across 6 years. Blood pressure and heart rate were measured, and even the exhaled breath was collected to calculate the gastric 50% emptying time. The conclusion of this very nice study is that in healthy older people over a period of time, here it was almost 6 years, there was an increased prevalence of postprandial hypertension and a modest slowing of gastric emptying. And the latter was, of course, related directly to a greater hypertensive response. Another pattern is very important to take into consideration is insufficient sleep. We know that people in Ramadan do have disturbances in their sleep schedule or sleep patterns. So this study is a crossover design study with two randomized groups with sleep deprivation or full night sleep at 1 week apart. The participants had to undergo sleep deprivation or a full night's sleep 1 week apart, and of course the blood pressure was monitored. So this is, as you see here, the diagrams of the blood pressure, both the systolic and the diastolic. The sleep deprivation group showed a high blood pressure and heart rate that was really higher than the other group. And this increase were more pronounced during the nighttime and the morning after a sleep insufficient night. So the data suggests that lack of sleep in hypertensive patients may increase sympathetic nervous activity during the night and the following morning, leading to increased blood pressure and heart rate. So this can be observed in patients during Ramadan where sleep is disturbed. There are also other studies that were collected in this systematic review that have shown almost the same results. Most of them did show the increase of blood pressure values. I guess 1 or 2 did not find a difference or other stress, but most of them did find the increase of blood pressure in the patients. That was explained, as we said, by the elevation of the sympathetic nerve activity and the immune system with the pro-inflammatory cytokines and the stress system, all of them contributing to hypertension. So we spoke about these factors, but there's another parameter that is very important. It is the fact of being stable, well-controlled, and adherent to the hypertensive medication. This was well pointed out in this research article in which Ramadan fasting was shown to reduce the cardiac stress among hypertensive patients that are controlled and adherent even without affecting their hypertensive state, as we see here, because there was no difference, objective difference found in blood pressure values during or after Ramadan. But then there was the stress was reduced, and there was evidence for that, making Ramadan fasting, suggesting that Ramadan fasting may be risk-free for patients adhering to their medication. And this is a very important thing to mention. So we saw the evidence, but the question remains, what could we tell our patients? What can we advise them? To fast or not to fast? That is the question. Because fasting in a hypertensive patient depends on the stage, of course, of hypertension, and also on the risk factors. And to this effect, there is this risk stratification for fasting in patients with cardiovascular condition that has also a part dedicated to hypertension. It's very recent. Here we got 2 levels of risk, the moderate and low level of risk in which the patients may be able to fast. And of course, there's no surprise to that. We put in this category the stable hypertensive patients. Then we have the high-risk category in which the patient should not fast. And it's defined by the poorly controlled hypertensive patients. So this is the risk stratification that can be very helpful for our patients, because most often hypertensive patients don't only present isolated hypertension. Most of the time, they do have multiple comorbidities, dyslipidemia, diabetes, chronic kidney disease, as 2 in every 3 patients with hypertension has a comorbidity. What's more, 2 in every 3 patients with comorbidities has hypertension. And of course, as I said, the hypertension control and treatment adherence are the key to allow the patient to fast safely. So the patient should be treated according to the update and managed according to the updated and recent guidelines. That means to prefer a single pill and to start with a dual combination therapy in most patients, starting with RAS inhibitors, ACI or ARBs, plus calcium channel inhibitors or diuretics. And if the control is not obtained, then to move on forward to the next step and to get to a triple combination, as we see here in this study, that has shown patients that have failed to reach the hypertension control with ACI and calcium channel inhibitor. In this case, the addition of indapamide, that is a thiazide-like diuretic, was very efficient in order to obtain the control of hypertension. And it's worthy to mention that this drug is really beneficial for high-risk patients presenting diabetes, CKD, and hypertension. There is another major risk factor that should be considered, and it is very delicate too when we speak about hypertension. It's chronic kidney disease. In fact, the impact of fasting of chronic kidney disease is really highly debated and problematic. So we're going to see here and to examine the evidence in the same way that we did with hypertension. And as there are doctors among us who are not nephrologists, then I'm going briefly to explain the CKD criteria and the stages, so we can speak the same language throughout the upcoming slides. Criteria for CKD are the presence of either one of the followings for 3 months. I mean, the markers of kidney damage. It could be 1 or more. That means albuminuria or albumin over creatinine ratio superior to 30 milligram per gram, or urine sediments abnormalities, or abnormalities detected by kidney biopsy or by imaging, structural abnormalities, or decreased GFR, glomerular filtration rates, less than 16 milliliter per minute for more than 3 months. And of course, the GFR categories enable us to stratify the chronic kidney disease into 5 categories or 5 stages. The complications that are preoccupying for us nephrologists to start from the stage 3, that is which matches a GFR less than 60 milliliter per minute. And the last stage, or the last category, is stage 5, in which the GFR is less than 15 milliliter per minute, and it's the stage of ESKD, end-stage kidney disease. So here again, let's see briefly the epidemiology of chronic kidney disease in Muslim countries. Did you know that in Arab world, there's a high prevalence of hypertension and diabetes mellitus as the leading underlying cause of chronic kidney disease? And that as the prevalence of hypertension in Muslim Middle Eastern countries increases, CKD prevalence increases in return, especially in countries like Saudi Arabia or Bangladesh, where the prevalence is very, very high. And this is somehow similar to the global trend of CKD, as we witness an increase, it's a sustained increase of the prevalence of CKD every year. So there are only few large prospective studies that have investigated the impact of fasting on CKD, and in this presentation will account for the published effects of fasting on CKD and ESRD and stage kidney disease based on the available data. Let me first tell you that all these studies are observational, owing to the obligatory or compulsory nature of fasting. We cannot, of course, randomize the population into groups of fasters and non-fasters. So an RCT is not possible. And again, most of the participants to these observational studies that are either prospective or retrospective are stable young patients in stage 3 CKD. The results are very different. They vary from an author to another. While some did not find any significant reduction in the GFR, some others have found an increase in creatinine and a deterioration in the renal function, with acute kidney injury occurring, urinary stones, and urinary tract infection also. And there are also some other authors who found an improvement of the GFR with fasting. So the results are very, very different from a place to another. We get to fasting in dialysis dependent and stage kidney disease patients. Now, this is really, this is not encouraged at all by nephrologists, because dialysis in itself is a catabolic state. But we have patients, here again, mostly young patients, who insist to observe the fast of Ramadan during the day off, the day without dialysis. Mainly, it's tolerated according to the published studies, but these fasters are more prone to hyperkalemia, to hyperphosphatemia, and also they do come to the next or to the following dialysis session with a higher interdialysis weight gain. So they are really at risk to fluid overload. I would advise you to read the systematic review, because it's one of the best systematic reviews about CKD and Ramadan fasting, in which the main idea is Ramadan fasting puts our CKD patients at a higher risk of complication, starting from stage 3 with a possible abrupt loss of renal function, and that there is a caution regarding the advanced CKD and diabetes or cardiovascular disease, that they are considered as high-risk patients that should not fast. Last but not least, I am very, very glad to share with you this very new publication about the consensus recommendations on fasting during Ramadan for patients with kidney disease. It was released some months ago, and in this in these guidelines, when we are confronted to patients with kidney disease who plan to observe the Ramadan fasting, then we assess them and stratify them into the low risk factors, which is the eGFR superior to 60, and in this case, fasting is probably safe. It's a low risk. The moderate risk factor, it's the eGFR 30 to 60, proteinuria superior to 1 gram per day, or the case of kidney transplant recipients for more than 12 months, or the patients with kidney stones. Here, it's a moderate risk. And fasting safety is really uncertain. Then there is the high-risk factors with the ongoing acute illness, acute kidney injury, eGFR that is low, less than 30, a dialysis patient with comorbidities, or a kidney transplant within less than 12 months, frail patients, or the patients who were considered low or moderate risk previously, but who had a poor previous fasting experience. So this is a high risk, and fasting is probably unsafe for them. These guidelines do match, in fact, our clinical practice in our nephrology units. And when we have patients that wish to fast, we do assist them, accompany them, and the monitoring consists of the adjustment of the dietary and fluid intakes, the adjustment of the medication doses and schedule if needed, and we explain to them the rules for breaking the fast if needed. And of course, they should be followed up in an expert's clinic pre, during, and post Ramadan. Usually, we explain to the very high risk and high risk patients to this. It would be interesting to explore alternative options, such as fasting on shorter days in the winter, for example, or to do fidya, for example. But some patients still choose to fast, and in this situation, education, optimization, and emergency plans should be established. So how do we accompany our patients concretely? Is that we assess the creatinine levels and the electrolytes in stable CKD patients. We also do weekly clinical monitoring, trying to assess the weakness, the edema, and the fluid overload in our patients. We advise them to avoid high potassium and phosphorus food, and to keep reasonable hydration. And of course, if the creatinine, the serum creatinine increases for more than 30%, or there are electrolyte disturbances, then fasting should be broken. We explain this to our patients. So at the end, I would say that fasting is well tolerated in stable, controlled hypertensive patients that are adherent to hypertensive medication. Of course, fasting long hours, especially in hot climates, increases the risk of acute kidney injury and chronic kidney injury and chronic kidney disease worsening. There are no meaningful influences of Ramadan fasting on renal parameters in a stable CKD patients, whereas high-risk patients are more likely to develop complications, so they require a close monitoring. They should break the fast when needed, and alternatives to fasting should be sought. All patients must receive individualized advice, close monitoring, and follow-up. And I would end by saying that there is a big lack of data to aid us, physicians, especially nephrologists, in fasting decisions in our CKD patients, and to empower us in order to provide the right decision to them. So controlled studies are essentials in this matter. Thank you very much.
Thank you very much, Ustada Haddiya Intissar, for this crystal clear presentation that is making the link between hypertension and Ramadan so clear. And thank you also for highlighting the important role played by the importance to control blood pressure for hypertensive, thanks to the right treatment, the right adherence, etc., and also making the CKD thematic clear for us and for the audience. Thank you once again. Do you have any question? Does the audience have any question?
Thank you for your nice presentation. I have one question. What's the best time to have the antihypertensive medication for patients with hypertension during Ramadan time? Which time is better to have the antihypertensive medication?
Yes, this is a very interesting question, and it was addressed in a multicentric. Well, it was not answered in a trial designed in Ramadan and about fasting, but it's a multicentric study named TIME, in which the right time to take the medication was assessed. There was a comparison between taking the antihypertensive drug either in the morning or at night. And what was found is that there's no significant difference whether the patient takes the medicine in the morning or at night in terms of efficacy of the blood pressure control. But when the patient takes in the morning the medicine in the morning, then there is more adherence. The patients are more adherent to the treatments. So after the release of the time study, which is a very strong study, we started advising our patients to better take their medicine in the morning. So consequently, in Ramadan, we advise them to take during the suhoor. And if there is any problem with that, they can take it during iftar.
Assalamu alaikum. Professor Intissar, I would like to ask about the MR antagonist, the Kerendia, and its use in cases on patients with CRF. And if you have any experience about its use during Ramadan, Kerendia.
I did not hear the question. I did not hear what you're asking about. Lina, please, could you tell me what the question was?
The MR antagonist, the Kerendia tablet, and the use during Ramadan. Is there any observations?
Antagonist? Which antagonist?
The angiotensin 2 antagonists.
Yeah, angiotensin 2 antagonists. Well, they're parts of RAS inhibitors. Of course, there's no problem with using RAS inhibitors, whether it be ARBs or ACI, during Ramadan or outside of Ramadan. The only condition to use these drugs is to observe a normal hydration state. You see, this is the main contraindication to the use of these drugs. So what we advise our patients when they fast is that they should keep a normal state of hydration, to keep, not forget to drink during the period after iftar until suhoor. This is somehow to compensate the hydration in this period.
Thank you, Professor.
I see a
Thank
hand.
you, Professor. So, we
Yes.
have not any questions about efficiency. Thank you very much.
Thank you.
Thank you very much. There is a hand here on Teams.
Yes.
It is Professor Mohammad Zalba. Do you hear us?
I hear you. Hello.
Yes, we hear you, Professor.
Good morning. I want to thank Professor Intissar for this very rich presentation. And as you said, fast or no fast, that's the question. And Ramadan helps to reduce cardiovascular complication in well-controlled and observant patients. During this healthy month, eating and sleeping activities are modified and can affect blood pressure. Then, do you think that in patient with triple therapy with the diuretic, can we stop use of diuretic? And in my second question, can we say that fasting is a progression factor, of not dialysis chronic disease, especially in patients which have comorbidities or renal stone. Even their renal function is stable.
Mhm. So thank you for your question. I'll start with the diuretics. You know, most of our patients are on diuretics, especially when they have CKD, diabetes, and hypertension. They're on dual or triple combination, including the diuretics, be it indapamide or else. And of course, we don't stop the diuretics because we need them to reach hypertension control. You know that our patients are very hard to control in terms of hypertension. So what we advise these patients, first, we don't allow them to fast if they're not controlled. And we see that, and we explain to them clearly in details all the risks all that can happen in terms of complications. And after that, when if they are controlled, we allow them, but then we accompany them. We assess their hypertension control, and we advise them, as I've said previously, to keep a good hydration state. Okay, but we don't stop.
Yeah.
And
Yep.
we don't change the treatment. And you know that because it's
Yes.
really hard to obtain the hypertension control. What was the second question, Professor Zalba?
The second question, if can we say that fasting is a factor of progression of renal disease in not dialysis chronic kidney patient, especially in patient with have comorbidities, diabetics, and renal stones, infection, even their renal function is stable.
Yes, a patient in with an active or acute kidney illness is not allowed to fast. This is an absolute contraindication. Of course, there is a high risk of kidney function deterioration. Regarding the stones, it's different. Okay, as I said, AKI do risk ATN, that means acute tubular necrosis. But for the stones, things are different. If the patient has only one small stone and he or she can be hydrated during the night, then it doesn't matter. If there is no renal colic attack, then it is not a problem. On the contrary, if the patient has got lots of stones or diseases in which the stones are multiple and the patient is at risk to renal colic attacks, then here, of course, fasting is impossible because it's too painful. Okay, in infections too, a patient in sepsis cannot fast. It's an acute condition in which fasting is not allowed. There's another thing, Professor Zalba, when you speak about, when you mentioned the active illness, it's the situation of the patient with proteinuria. When a patient has a proteinuria superior to 1 gram, I suppose that's what you meant with the stable patients. The patient maybe does not have a low GFR, but the proteinuria is superior to 1 gram or nephrotic, then the patient loses way too much protein in the urines. Then this patient is not allowed to fast, of course.
And one of my question in our countries is making very hot. And we remark that in Ramadan, we have a high frequency of colic nephritic secondary to stone. And patients are young and AKI, acute kidney injury. Then if they ask us to stop fasting, what answer
Of course, they are allowed. Of course, they are allowed. Nobody can fast with a colic, a renal colic attack. Okay, this is an absolute contraindication. Of course, as I said, it's too painful. It's extremely painful.
Yes.
And when these patients come to your visit and ask whether they can fast, of course, you assess. That's what we do in our consultations. We assess. And then we see if if the two kidneys contain much stones. Of course, the patient cannot fast. I see, and because in Islam, Ramadan, it's mandatory, of course, but we say in Arabic, ad-dinu yusr, the religion facilitates for the believers the accomplishments of the religious acts.
Thank you very much, Ustad
Thank you
Intissar,
for
for your
presentation.
answers. We have a hand
There is a
up,
question?
which is, yes, this is Professor Mohammed Hassanin who has his hand up. So raise it, please.
If I may allow to make a comment on the questions the last two questions being asked. It's very beautifully answered by Professor Intissar. I just want to support an important issue. It's not just about the damage to the health. It's about the burden of fasting, because the ayah, the Quran says, وَعَلَى الَّذِينَ يُطِيقُونَهُ, and the word yutiqunahu is translated as the burden, as if it's like a talk, as if it's like a ring around the neck. And that talk, that ring could be very loose, could be very tight. So a person on diuretics, a person with renal colic, a person with stone, you need to assess not just the safety and the health of the person, but the burden of the person. The Quran does not want any person for any ibadah to be at a burden. And that's why when we travel, we can not we are allowed not to fast, or we can do the salah as 2 rak'ah instead of 4. So equally, if the treatment you're giving your patient or the condition of the person will be affected by not able to drink or eat or rehydrate themselves, then of course they are allowed, if there is no alternative to this, to not fast. Just wanted to discuss this point, because in our guidelines we had lots of discussions with the Mufti, and the scientific advisor of the Mufti, who is a professor from Al-Azhar University, did explain to us all of these important points. So it's not just about my patient could be in dangers on their health, but also the burden of fasting. وَعَلَى الَّذِينَ يُطِيقُونَهُ فِدْيَةٌ طَعَامُ الْمِسْكِينِ.
Thank you. Thank you very much.
And I think that we come to the end of this very beautiful moment of exchange. So we would like, Lina and I and all Servier, we would like to thank you very much, Professor Hassanin. Professor Haddiya, also we thank you very much for your highly interesting presentations and information for these patients. So thank you all for your attendance, and see you next time, inshallah.
Thank you very much.